Hi, today's lecture is on swallowing in patients who have tracheostomies or tracheostomy tubes. Let me bring up my slides. Here they are. Share. Right. So what we're going to be talking about is, first of all, the issues that arise when, in terms of swallowing for persons who have tracheostomies or tracheostomy tubes, and also how we assess swallowing in such persons and how we manage the various swallowing issues that they have. The first thing I want to talk about is the reasons patients have tracheostomies. What is a tracheostomy? It is an opening through the skin and into the trachea. So that's the ostomy part of it. It's simply an opening. And inserted into that opening would be a tracheostomy tube to maintain the opening and make it able to be utilized for the various things I'm going to be talking about here. So why do patients have tracheostomies? First of all, they have it in order to maintain an airway when there is enough of an obstruction to airflow to threaten health. This can be in, for example, persons who have sleep apnea. They have an obstruction which can threaten their health. And occasionally, there are various, of course, other less extreme treatments for sleep apnea, but occasionally, even now, with all those treatments, some persons do require that opening and a tube in it in order to maintain an opening for breathing at all times. Another reason, and a relatively uncommon one, fortunately, but is that there might be a laryngeal airway obstruction or other anatomical or physiological impairment that partially obstructs the airway. So, for example, a tumor or a cancer could grow in the airway enough to obstruct breathing. And that person would then need to have that opening into the trachea, a tracheostomy with a tube inserted into it. And they would then have a tracheostomy tube to maintain their breathing in spite of the obstruction at some point above that opening. Another one would be a vocal fold paresis. Occasionally, thankfully it's not frequent, but occasionally there's a complication of thyroidectomy, for example, that results in paralysis, partial paralysis of the vocal folds, hopefully just on one side, but sometimes on two sides, which can occlude the airway enough that the person cannot breathe without that tracheostomy. A second and more common reason would be to provide a route for positive mechanical ventilation. So when somebody needs to have their breathing assisted with a mechanical ventilator, they will have usually, first of all, an endotracheal tube inserted, which is a short-term solution to their issue, and later a tracheostomy tube. And in the next slide, we're going to look at what that endotracheal tube looks like before we get into the tracheostomy tubes. And then the final reason, and a more common one than the first of those, is to protect the airway against aspiration of secretions or of things that might be eaten or for drinking. Now, why would somebody have this kind of a problem? Because they have impaired consciousness. Somebody who's in a significant coma would be a reason why they need to be protected against their own aspiration of secretions or against prandial aspiration. And also somebody might have severe dysphagia, including, but not limited to, persons who have an absent pharyngeal swallow response. They may need that tracheostomy. Okay, so now let's look at some background information on the endotracheal tube, the tracheostomy tubes, ventilators, connectors, and also one-way speaking valves as a prelude to getting into how do we assess swallowing. So what's an endotracheal tube? The endotracheal tube is pictured here, and that is the tube that is inserted into the airway in emergencies. It's the first thing that would be done in somebody who cannot maintain an open airway, or if they cannot breathe by themselves and are going to need the assistance of a mechanical ventilator, they will insert an endotracheal tube that looks just like this. And you can see that it goes down beyond the vocal folds into the trachea. And then this little piece is like a cuff that is, it's called a cuff actually, that gets inflated. You cannot see it in this particular one, and you'll see it later, but there is a little tiny tube next to this bigger tube that comes out here and can be inflated with air to inflate this so that it forms a light seal against the tracheal walls. And that enables the person's lungs to be inflated with air under positive pressure that is pushed in through this connector to a ventilator. The ventilator is not shown here and the connector is not shown here, but here's the connector, and you just plug it in basically and set the parameters on the ventilator, and it will cause the person to receive and then to exhale air. It's the endotracheal tube is, as I said, inserted in emergency conditions and is typically used for up to 7 days. It's also, by the way, inserted during surgery when persons have a general anesthetic in order to control their breathing, and also to provide protection in the event that they may have a vomit. And because of their reduced consciousness, the vomit could then be aspirated, which would be a very dangerous thing. So typically in surgeries, when there's a general anesthesia that's going to be used, the first thing they do is to insert the endotracheal tube. After they have a very light anesthesia, they'll insert that. And then they'll use it throughout the surgery. And after the surgery, they'll, as soon as they attain a little bit higher level of consciousness, they'll just pull that out and they go on with their recovery process. So again, typically used for 7 days. Now, why only 7 days? Because this tube is going through the glottis, and it is somewhat traumatizing to the structures of the larynx and the glottis especially. And it's been found that people who have endotracheal intubation for more than 7 days tend to have complications with voice and also with swallowing at a higher rate, because they get swelling and edema in the vocal cord area, and that precludes normal phonation as well as normal closure, laryngeal closure during the swallowing process. So if somebody needs this route of ventilation for longer than about 7 days, that is when they would receive a tracheostomy, which is an opening from the anterior wall of the neck through the skin and into the trachea, and then an L-shaped tube, which you'll see in just a moment, is inserted into that opening. All right, here is the first of several tracheostomy tubes you're going to look at. And I picked it because it's a very common brand, first of all, Shiley. If you work in an acute hospital, that's mostly what you'll ever see in an acute hospital, will be a Shiley cuffed tracheostomy tube. And I'm showing it to you first because it sort of has everything that you would ever need to know about the anatomy of a tracheostomy tube. So I want to go through those different parts. I'm going to skip down here to the connector, which would be called also a hub on this tracheostomy tube, and that protrudes through the anterior neck. You will see that if you just look at a person who has this. And then next to that and next to the skin of the neck would be this thing, which is called a phalange. And you'll notice it has 2 little openings in it. The phalange is actually just held in place by a ribbon that is tied through an opening on one side. Then the ribbon goes around the neck and comes up to the other side, and it's tied, and that holds the whole thing in place. So now we have the connector or the hub, the phalange, and then we have this part of the tube that we can easily see, not when it's in somebody, but when it's sitting here, like we're looking at it right now, the outer cannula. And let me just jump ahead to say that there's an inner cannula that fits into the outer cannula. The purpose for having these 2 cannulae is that for cleaning, you need to remove this and clean it, or just throw it away and put a new one in. Otherwise, what happens with the cannula, if you only had 1 cannula, secretions would get in there and they would dry, and they would, over just the course of not too long, a couple of days it could be even, or less for somebody who has a lot of secretions, the diameter of that cannula would reduce. more and more and more to the point where the person couldn't really breathe adequately. So that is prevented by having an inner cannula inside the outer cannula. This can be easily, conveniently removed, cleaned, or thrown away, and they do throw it away every 24 hours routinely. And then they put in a new one, and there you are. So we have the inner cannula, the outer cannula, and then on this particular one, we have the cuff. And the cuff is a little balloon that you also saw on the endotracheal tube that can be inflated. And here is the connector line that inflates it. You can see it goes, it's a very small diameter line. And this little thing is called the pilot balloon. And then there's a one-way valve that allows air to go, basically it blocks the air unless you push a syringe, just like you would get an injection. A syringe fits in here and you can inject air to pump this up a little bit. When that is inflated, you can easily see it because this will be hanging outside the whole thing. You can see it on, usually it's under the bedclothes or the pajamas, but you can see this thing, and you know, because you see this little tube, you know it's a cupped tube, and you can look at this or feel it, and you see that it's got air in it. It's not flat, it's got air in it when the cuff is inflated. All right, so I think we've got all the parts. We've got the cuff, the outer cannula, the flange, the connector, the inflation line. Here it is. Oh, excuse me, didn't mean that. And we've got the pilot balloon. And then over here, we've got the cuff shown with the inner cannula removed. And please look that this looks just like this. What one would do in order to remove that is just give it a little twist, and then it pulls right out. And then this thing is called an obturator. And the only time it is used is when the tracheostomy tube is placed through the stoma, through the neck, the skin of the neck, and into the trachea. So that is just, normally you don't really, as an SLP, you're not going to see it. It's not going to be there. It's used only when they put this thing into the neck, excuse me again, and then they take it away, and that's it. So I think we've identified everything about a shyly cuffed tracheostomy tube. Let's go to the next one. This is a shyly cuffless tube. So the most important thing is, you look down here, there's no cuff. So there's no line to a pilot balloon either, because there's not going to be any air. Here, it still has the outer cannula. It has the inner cannula, and you can see here a little more detail about how it gets connected. And I had incorrectly said that it is twisted a little bit. It's not really twisted. You just put your fingers here and squeeze those together, and it unhooks itself, and it can be readily pulled out. And here's the obturator. So I think we've identified everything here. You can see it's a little simpler. They've also shown here a cap. And a cap is used to plug the tube totally. It would go up here. It plugs right into or onto the hub. And what that does is block the air. And why would you want to block the air? They do that before they pull the tube out to ensure that the person can breathe adequately without reliance on the tube. They can breathe, they can swallow if they're swallowing and eating. They can do everything they need to do without reliance on the tube. And after they've done that for a short period of time, could be a few hours, more likely a day or two, they'll just pull the tube out. And that stoma, by the way, heals and closes spontaneously by itself rather quickly in just a very short amount of time, like several days. It'll be too small to reinsert this tube if it were needed. So they want to make sure that doesn't happen. Therefore, they just plug the tube. All right. This is a different brand. It's a Portex cuffless tracheostomy tube. And there are just a couple of differences I want to point out to you. You'll note that it has a flange. It has a outer cannula. It has a different color hub here, but that doesn't really matter. It's just different color. And it has an inner cannula. Now, you don't see the whole inner cannula, but the inner cannula is a smaller diameter tube that fits into the outer cannula. The key difference here is that this, instead of having that that hub that you unclip and pull out, it's just got a little ring. It's a little ring. And you just kind of, it's only attached at one spot, like it could be here. And so it can be pulled up, like this is a hinge, it can be pulled up, and then that gives you something to grab and you can pull it out. So that's the only difference. As an SLP, the one thing we want to remember is that this kind of a tracheostomy tube, the Portex, is contraindicated in somebody who's going to be using a Passy-Muir speaking valve. The valve speaks over here, and it's got a little diaphragm in it that has to freely open in order to allow the person to breathe. And there's a potential that this ring could be not in this position, but in the little more pulled up position that would occlude that diaphragm and prevent the person from being able to breathe. So we may test somebody for use of a Passy-Muir valve with this Portex cuff, cuffless tracheostomy tube, or it could be cuffed, by the way. They do come with cuffs, but the idea is the Portex. We could test somebody for the use of the Passy-Muir speaking valve, but we wouldn't leave them alone because there'd be the potential that somehow something goes wrong and this occludes the diaphragm and they can't breathe at that point. Now, in terms of the kinds of practice settings there are, Portex tends to be used in long-term care, and Shiley tends to be used in acute care. Shiley is a more expensive product. Portex is a little less, and that's why they use it in long-term care, where the costs of long-term care quickly stack up. So they're looking for anything that they can, save a little money on. All right, this is something that is related to what we've been talking about, and it's a closed suctioning system for an endotracheal tube or a tracheostomy tube. I'm going to go back just simply to a tracheostomy tube and explain the significance of tracheal suctioning. Let's go to this one. It's just fine. Oh, no, actually, let's go to this one because this is complete. It's got everything in it. As people who have tracheostomies will tend to also, now it's not 100%, but they'll tend to also be unable to cough up their secretions. And so as many times you'll walk into a room and you'll hear, as they breathe, you'll hear the rattling of a lot of secretions down there, and you may see secretions coming out around the stoma, some coming through the tube, but the point is they're not able to clear it because they don't have an adequate cough. And so what typically nurses would do this, or respiratory care practitioners who take care of breathing issues and including tracheostomy tubes, they'll come in with a very small diameter tube attached to a suction unit on the wall, and it's got to be sterile, and they'll push it down through here and maybe about 6 inches or so past the tracheostomy tube and into the trachea and even into the bronchi. Of course, they never know which bronchus they're going into, but they're suctioning up secretions to clear it. And typically after they've been suctioned, you'll hear that their breathing is clearer and they're not coughing things or passing things around the stoma or through the tracheostomy tube nearly as much, maybe not as all. And that may need to be done on some patients several times a day. It could be every hour or 2 hours sometimes. But every time they do it, they need to do it completely in a sterile manner. So they'll get out a brand new kit. It's got everything I just mentioned, the little tube to pass down through there. That has a connector to go to the vacuum unit on the wall, and they'll have to use gloves. They lay out a sterile field with a blue paper cloth so that nothing touches the bed. And then when they're all done, they'll throw the whole thing away. So when patients need frequent tracheal suctioning, what they're going to do is they're going to, instead of doing what I just described, they're going to do the same process, but with a different kind of setup. They're going to use something called a closed suctioning system. And here you can see the whole thing. It would come in a package, but then they're just going to leave it on the patient. This end attaches to the suction unit, a tube that goes to the suction unit on the wall. This end attaches to the hub of, it could be an endotracheal tube, or it could be a tracheostomy tube, and it can be a Shiley or a Portex, doesn't matter. This is a little end to allow for connection to the ventilator, so the ventilator could be here, and it goes off into a kind of a large diameter tube that goes 3, 4, 5 feet to the ventilator. We'll look at that later. This is a little cap that can come off to inject medications that could be breathed in. This is a little tube for injection of medications. Then this is inside here. If you look very carefully, you'll see a small diameter tube, which looks just like the tube that would be used in the disposable tracheal suctioning kit. However, it's enclosed in a sealed plastic bag. And what will happen then is that the nurse or the care practitioner, or sometimes the SLP, will take a hold of this and start pushing it through so that the tube comes through here, through the hub, down the tracheostomy tube, down a few inches below. And then they have it's not pictured here, but on the vacuum, on the tube that goes to the, it is pictured here. This is a button that can be depressed, and it allows the suctioning that's going on to actually suction. In other words, if it's not depressed, the vacuum on the wall is ready to suction, but it's not being allowed to because this is occluding it. And it allows the nurse or the respiratory care practitioner or the SLP to control when suctioning is actually occurring. The reason for that is that when the provider, the caregiver inserts that tube down, they don't want to suction continuously because it's a little too much. It'll actually suck all the air that the patient would be breathing, but they're not because it's all being suctioned out. So it allows for control of it at only intermittent periods during this. Could be a 15 to 30 second process. 30 seconds a little long, but let's say 10 to 20 seconds would be kind of typical. So it allows for not having to get a new kit out and dispose of it, but simply to have it there. Then when they're all done with the suctioning, they'll simply disconnect this from the tube that goes to the vacuum, and it'll hang outside the patient's hospital gown, and so you'll readily see it. So we've got a tracheostomy tube coming out, and this is attaching to this thing, which is, by the way, I didn't name it. It's a T-bar. You can sort of see why. T-bar or T-piece. And it's just going to be hanging there. And then next time they need to suction, they'll come very quickly. It's easy. Attach the suction tube from the wall to here. Start pushing until they get it down the tube into the trachea, or maybe as far as the bronchi, and then press the button and start suctioning as they pull it back up. And typically they'll also try to rotate it a little bit so the suctioning kind of wipes around the trachea rather than just go up one side. All right. Now, so this will be used with it. You'll see it all the time if you work in LTACs, long-term acute care, also sometimes called subacute units, or in the acute hospital. You'll see these frequently. That would generally be in the ICU, by the way. All right. Here is a picture of somebody who is receiving suctioning of the endotracheal tube with that closed system. So it's an endotracheal tube. So see, no tracheostomy tube through the neck. The tube is going down through the oral cavity, the pharynx, and down through the glottis into the trachea. The cuff would be inflated. We can't see the details of that. And there is a connector right here. Here's that connector. So if you go back and look at that first slide of an endotracheal tube, you'll see that several inches of the tube come out. It's flexible, by the way. And then there's a connector, and here it is. It's connected, and it is connected to, we can't see this very well, but it's connected off to the side to a tube that goes to the ventilator. Here you can see that blue and white tube. The blue tube provides the inflow, the white tube provides the outflow, and it's all connected about here, sort of on the other side and inside this caregiver's hands. And then here is the closed system suctioning down here. There's the bag with a little tube inside, and they're starting to push it in. Same thing would be done with a person who has a tracheostomy. Here is a full view of a patient and a ventilator setup. So I just wanted you to kind of have the general image of how this looks. Here's, of course, here's the patient. You can see that. Here is a here is the line to the ventilator. You notice that there's a blue part for the inflow and a white part for the backflow or the exhalation process. Here is an endotracheal tube. This one is another endotracheal tube. And here is the ventilator itself. They come in various forms, by the way, and they even sometimes little boxes that are a little bigger than a shoebox, let's say, that can sit on the bedside table. You tend to see those in long-term acute care or subacute units. These more elaborate setups are in acute hospitals, and some LTACs have them too. But it has a monitor, it has various settings we'll look at in a second. We're not going to look at the details of the setting, but we're just going to look in general. So here is a monitor of a ventilator, and you can see that it's showing the various things about the breathing. It shows also the O2 concentration, so it can control the concentration of the air in terms of the O2, amount of O2 that is being given to the patient. If the patient needs more oxygen in order to maintain enough oxygenation, they can pump that up. They can also change the respiratory. They will set the respiratory rate. Typically, for an adult, that'd be in the range of 12 to 20 respirations per minute. They can change the tidal volume. Typically, an adult, that might be 500 to 750 cc's per breath. Those will all be set. So potentially the ventilator can deliver exactly what is set. And you can see what's happening too. Now, before going to ventilator modes, let me just jump ahead 1 second. There's one thing I'm not showing on this particular image, and that is the ventilator mode. That's a setting on the ventilator that it dictates how much work the patient's going to do and how much work and the nature of the work that the ventilator is going to do. The ventilator can do everything and the patient does nothing, or it can be set so the patient does everything, and if the patient doesn't do enough, doesn't take a big enough breath, for example, it kicks in. So there are about a half a dozen, we'll look, there are about a half a dozen settings for different patients under different circumstances. But before I get to that, I want to talk about the coordination of breathing and swallowing. And the reason for that is especially important in the use of ventilators, because the ventilator, if it's doing all the work, isn't coordinating anything with the patient's swallowing, and it will tend to throw the whole thing off. So what is the normal pattern of coordination between breathing and swallowing? The normal pattern in a person who is not on a ventilator and doesn't have a tracheostomy is that when you're going to swallow, and you don't do this every breath, because you'll sit there and breathe in and out for, I don't know, could be half a minute before you swallow. So the normal pattern when you do swallow is that you inhale, swallow, and exhale. And the reason for this pattern, which is sort of programmed in, is that it provides the maximal protection against penetration or aspiration, I have of, but I meant or, of secretions or food and liquid if the person is eating and swallowing. Now, in everyday life for normal people, or anyone actually, the normal pattern can be overridden by voluntary control. In other words, I could decide, okay, I'm going to exhale now and then swallow, and then I'm going to inhale and see what happens. Well, you can do that, and probably nothing will happen. But that is the normal pattern, is that we are automatically, not even say reflexively, I said automatically going to use this inhale, swallow, exhale pattern whenever we do swallow. And also in everyday life, of course, sometimes we're not paying attention. If we're eating and talking or laughing, that pattern can be easily disrupted, and that would tend to be when people might choke or cough. So that's all kind of normal, but that would be our strong tendency, is to inhale, swallow, exhale. Now, when you're on a ventilator, and receiving mechanical ventilation, the ventilator is going to breathe for you sort of when it's been programmed to breathe, whatever it is. And we'll look at those and how they might impact swallowing in the next slide. But it's going to just do what it does, what it's been programmed to do. And irregardless of when you choose as a eater, swallower, to swallow. So that can bring problems about. All right. So now the ventilator. The ventilator mode is one additional setting on a ventilator. Excuse me, didn't mean that. And it is a very important one. The ventilator mode setting determines how much work and the pattern of the work that's going to be done by the ventilator versus what the patient's going to do. And I want to stop sharing this for just a moment and go to a document that is posted, I think, second from the last in this particular module of Canvas. Let's take a look at that. I'm going to share a different document, which is this document. And I put it separately so that you could print it off and kind of carry it with you and actually, refresh yourself. So this is, outside the scope of practice of an SLP, and SLP is not going to determine what the mode would be. But your patients are going to have a mode if they're on a ventilator. It's one or the other, and we sort of need to know how might they impact swallowing. So I'm going to go through 2 or 3 of these. I'm not going to go through all of them. You can study them on your own, and you'll get familiar when you start seeing patients who are on ventilators. But the first one, it's called CMV, or controlled mode of ventilation. So the doctor would actually write the order for one of these. Typically, they'd write the order, and then the respiratory care practitioner who sets up the ventilator will dial it in, and that's what the mode will be for that patient. And with CMV, the ventilator provides complete control over the volume and rate of each breath. So the patient doesn't do anything, really. They don't decide on how deeply to breathe. They don't decide how fast to breathe. They don't decide when to take a breath. It's all going to be automatic. And so then let me take the next one just as an example for how we would think about this in terms of swallowing. Under assist control ventilation, AC, the ventilator provides a preset volume every time the patient initiates a breath. See, there's the key thing. In this case, the patient initiates the breath. So the patient gets some control over the timing. But it also ensures a preset minute volume by independently breathing if the patient does not initiate enough breaths. Now, what's a minute volume? That is the volume of air, oxygenated or not, the volume of air that the person is going to take in their all their tidal volumes or tidal breaths in 1 minute. So let's say you take 500 cc's per breath, typically as your particular sized individual, and you do it 12 times a minute. That's be 600. So that gets dialed in actually when they're going to use assist control. The physician is going to say, and make sure they have a minute volume of 600 cc's of air per minute. So if the patient is lagging behind either in terms of initiating breaths or not taking a big enough breath, the machine will start to do it for them. The ventilator, I should say, not machine, will start to do it for them. In which case the patient loses some control. But what's the upside? The upside is they get enough oxygenation. So the way it typically works is controlled mode ventilation is going to be used on the sickest people, the ones who can do the least, usually early on in the course of this whole mechanical ventilation scenario for that particular individual. And then as they gain some strength and independence and start to get better, they're going to start to dial it back so that the patient starts to do more of the work. Now, that's a very important part of recovery, actually. They do want to dial it back because if the machine keeps doing everything, the patient gets weaker and weaker and weaker. And then when it comes time to, maybe they've recovered in many ways and they'd like to get them off the ventilator, but they can't because the patient has become very dependent on that ventilator. So part of the recovery process is to start dialing it back so the patient does more of it. So read through these, and I think they're very logical, and you'll see. It's not in the scope of practice for SLP, as I said, to decide which one, but you'll have to deal with whatever your patient is on. And a lot of times we get an order for a swallowing evaluation on patients who are on controlled mode ventilation, and we'll go ready to do it. And we might want to even use a Passy-Muir speaking valve, which we'll get to later. And the RCP might say to us, oh my gosh, I don't think they can do it because they're on controlled mode ventilation and they have a whole lot of secretion. So that's a kind of a complication for us, and one that may not bode well for swallowing at that particular point in their recovery process, but hopefully later on. Okay, now so enough said about this. Remember that document is there, and I'm going to stop sharing that and go back to the slides and pick up where we left off, which I think is right here. Yes, okay. So let's see, I think we covered all of that. So you're going to review the document that I just showed you, and I'll ask you to identify which mode would be the most disruptive, and it is the first one that we talked about. And you can look at each of the others are less and less, and they can be set to the point where they're doing all the breathing, but if they don't do it, it kicks in. All right. Now, turning in a slightly different direction, we are going to start talking about Passy-Muir one-way speaking valves. And I hope that by now you have looked at those 6 short videotapes, totaling only 16 minutes for all 6 of them, that are made available by Passy-Muir, the maker of the speaking valves. And they're very, very good. They're very good. And I sequenced them in a certain way so that I think that they support learning if you could take them in that order. So do look at that. You just stop this and go look at that if you haven't already done it. And then you'll have a good understanding already. So this isn't totally new information, but it's a little elaboration, and just to make sure. You will see as you look at those videos that are basically 2 different types of Passy-Muir valves. They come in different colors, and they're more than 2, but not many more. I think maybe 4. And they differ in certain ways, but the key difference between the 2 categories that I'm talking about is some of them are made for use with a tracheostomy tube only and no ventilator, and some of them are made for a ventilator and a tracheostomy. In other words, they kind of go between the 2 of them. And by the way, that latter one, the one that's made for use with a ventilator, can also be used if there's no ventilator. But typically you would use what we're looking at right now, which I've just given you the model number, Passy-Muir valve 2001. That's the model number. And this end of it on your left connects directly to the hub of either a Shiley or a Portex tube. So you just give it a little twist. It doesn't have threads on it like, if you're not really going to twist it on and make it tight. You just give it a little twist with a little push, and it will connect up. And you want to do it just enough so it's not too hard to get off, but so it won't blow off, because if you don't put it on enough, first time the patient coughs, the whole thing will blow off and shoot across the room, in which case you have to buy another $275, I believe it is, Passy-Muir speaking valve. So the different parts of it are the connector, and then this thing, which you can sort of see, but in the videos you'll see that really well. This is a very flexible diaphragm that opens during inhalation, in which case the air goes this way in, and it closes immediately upon exhalation, or even as soon as you stop inhaling, it closes, which is why it's called a closed biased valve. And the videos will explain that better. I do want to point out that it's purple, and the reason it's made purple is so that it's very, very visible to anybody who's taking care of that patient that they have this on. So we want all the caregivers and the family and the patient themselves, to the extent they can, to be aware that they have a tracheostomy tube present. This is a Passy-Muir one-way vent valve. So it's a PMV 507, and it's right here. You will note that it's a different color. And the other difference is that it's made so that this tube that goes to the ventilator twists right onto it. It's about, I'd say, three quarters or maybe 7/8 of an inch in diameter, and it just fits perfectly. It's made that way. And the other end fits right on the T-bar. Remember the T-bar? Might have to go back. Um, and then in here is this thing called a step-down adapter, which is simply to make the two parts attach. That's all. It fits. It's got 18 millimeters on one side and 25 millimeters on the other side. Makes it so the whole thing fits together. Here's our line to the vent. Here's our closed suction system. See? And you'll note that the tube for the vent valve, the valve itself, is off to the side, but also very close to the patient. They could put it any place because it can be made to fit any place along here all the way back to the vent. But the further you put this from the patient, the harder it is for them to breathe because they're having to breathe through a longer tube, basically. So it's supposed to be close to the patient. But it couldn't be here. I mean, somehow you could set it up so it's here, but then you couldn't use the suction tube. All right. Here is the full line of Casimir products. And so here's a very original trach valve, Casimir trach valve. Here you can see that they all have a diaphragm. You can't really see the diaphragm in detail, but the diaphragm is on this end. Here's the diaphragm. Here's the diaphragm. Here's the diaphragm. They all look like spokes of a wheel, and that little diaphragm goes right up to it. And when you breathe in, it kind of pulls away from it. It's attached in the middle, attached in the middle at that hub. And then it closes. It's got the close bias. So as soon as the person stops breathing in, it closes. Here's a certain kind of connector. I'm not going to talk about this. These four all do exactly the same thing. They are for use with a tracheostomy tube, but not a vent. It won't fit that blue tube. This, which operates in the same way, but it has a different shaped end to it that fits into the blue tubing that goes to the vent. So that again is the PMV, not OMV, PMV 007. Okay, here is the adapter. And you can see it's small on one end, big on the other end. So this end goes into the small end of a Casimir valve, and then it fits onto the hub. And this end goes on in the blue tube. So actually, I just said that wrong. This smaller end goes inside the Casimir valve, and this goes onto the T-bar. So I think we'll see that better in another image, and certainly it's shown very well in the video. So please look at that video. All right. Now I want to look at, now that you've got an introduction to the valves, and together with the videos, I think that gives you enough information. Have a pretty good understanding. I want to look at the traditional perspective on causes of dysphagia with tracheostomy. And these are the ideas. One is, why would somebody who has a tracheostomy have a dysphagia? Well, one is that they have a disease or an injury that caused them so much dysfunction in this area, which also affects swallowing, by the way, that they needed a tracheostomy. And so it's the disease or the injury that can lead to the dysphagia in such a person. The second is that people who have tracheostomies will tend as a population to have deconditioning. And we know about the relationship between deconditioning and dysphagia. So if somebody didn't have a neurologic injury and they didn't have a mechanical injury to this area, but they had some other problem that was a medical problem that caused them to be so sick that they needed a tracheostomy, and they basically aren't getting out of bed or doing anything, become deconditioned. If they didn't have dysphagia first, they might have dysphagia after that. Then the third idea is that the tracheostomy itself may cause a dysphagia. In other words, if you put it into somebody who didn't have dysphagia, if you put a tracheostomy and a tracheostomy tube into somebody who didn't have dysphagia, they may have dysphagia now. Why? Because several things happen. One is that there is a restriction of the normal pattern of laryngeal elevation. Um, and why does this happen? The reason it happens is because you're putting a hole through the skin of the neck, through the trachea, and then a tube through it, which does what is referred to as tethering, tethering the larynx down. It's keeping it from having its normal degree of elevation because you're sort of locking it to this place on the front of the neck with a tube that goes through the skin and then the trachea. What does that do? Well, one thing is it alters the closure of the adytus laryngeus because you remember you partially close the adytus laryngeus through laryngeal elevation. Also, retroflexion of the epiglottis, but that in itself is not enough. You need the elevation of the larynx. Remember the other thing that the elevation of the larynx is needed for in terms of the pharyngeal swallowing process? Opening of the UES. So those are two ramifications or effects upon swallowing created by the presence of the tube through the skin and then the trachea. The second is a reduction of the normal pattern of subglottic pressure elevation during the pharyngeal phase. So when you are going to swallow, remember you've taken a breath in. That's the normal pattern. You take a breath in, and then when you get to the pharyngeal phase, you close the larynx, and there is then elevated subglottic pressure because you got a lot of air in the lungs and you close the larynx. And then as soon as you finish the pharyngeal process, that pressure is released and it'll tend to have that effect of moving materials that might have penetrated the larynx up and out to be swallowed again. The third is alteration of the normal pattern of throat clearing or coughing. When a person who has a tracheostomy tube coughs, they don't get any airway through the they don't get any airflow through the upper airway past the point of the tracheostomy tube. It all comes out the tube. So when you start to get materials gradually or one way or the other coming down into the vestibule and even down into the vocal cords and below and sitting up on top of the tube, it can't be coughed out. The person is not capable of doing that. Likewise, they cannot clear their throat. So you'll tend to get an accumulation of materials that are coming down and they cannot be coughed out except through the tracheostomy tube, which is somewhat good, but not as good as clearing the whole upper airway. Typically, if we get something into our vestibule, we do cough and then we swallow and we clear it. And the third thing that happens, and this is for people who are on the vent, is the alteration of the normal breath-swallow pattern, which you know about. The normal pattern is inhale, swallow, exhale. And this pattern provides for natural and repeated upward flow and clearance of the material. And especially when somebody is on assist control, they're not controlling their respiration at all. And they're not really aware of that. I mean, they tend to just lose the connection. There's a disconnect between breathing and swallowing because breathing is being done by a machine. So that is another complication. That's why somebody who could swallow may not be able to swallow safely and effectively after a tracheostomy. Now, I want to add just a little complication to that. I posted this study by Lader and Ross, who are from Yale University Medical Center. They're very well-known researchers in dysphagia, and they completed this very interesting study in 2010 and published it in Dysphagia. And they concluded from their study, and I'll tell you a little bit about how to do it, but it'd be a good idea for you to read it. They concluded from their study that the only people who had tracheostomies who developed dysphagia were those who would have had it from the etiology to the whole process anyway. In other words, if they didn't have dysphagia before the tracheostomy, and they didn't have an etiology for dysphagia before the tracheostomy, they didn't have dysphagia after they got a tracheostomy. Therefore, they concluded the tracheostomy in and of itself does not cause dysphagia. Now, the way let me see what my next slide is now. Coming back here. The way they did the study was very interesting to me, and I just didn't quite understand it. They had the opportunity somehow at Yale University Medical Center to see people for swallowing evaluation before they had a tracheostomy. And then they repeated the evaluation after they had a tracheostomy. And that's how and then they were able to look at the etiologies and why people had the tracheostomy. And they saw, if they didn't have dysphagia before, they didn't have dysphagia after. But if they did have dysphagia before, they did have dysphagia after. That was the strong tendency. And it was all, statistically significant and everything. The thing, and they had a variety of etiologies, by the way. The thing I didn't understand is I have never seen a patient for a swallowing evaluation who was going to have a tracheostomy, but they didn't have it yet. And the reason for that is typically people, let me take a very common scenario. Somebody who has COPD or emphysema, and it's getting worse and worse, and you see them with the oxygen tank and the tube and everything in the community. And then one day they reach a point where they just simply can't breathe adequately, and they go to the ER. And they can't breathe. They're not maintaining their oxygenation. And typically what they'll do then is they'll put an endotracheal tube in and start mechanically ventilating them. And then they'll send them to the critical care unit. And then if they can stabilize them, they'll pull that endotracheal tube out. And sometimes we'll see those patients because they've had the endotracheal tube for a while and there is a risk for dysphagia. More often than that, we're looking at the ones who they can't reach the point where they can take the endotracheal out, and they've gotten to their 7 days. Remember the 7 days, roughly speaking, by the way. So they do a tracheostomy. And now, because the patient was eating before they came to the hospital, they'll say, okay, can we, let's do the swallowing evaluation and see if they can eat. That's who I've seen. Many of those patients. And some of them can eat afterwards, right away, but most of them cannot. They can maybe eat a modified diet, but we have to work with them for a while to try to get them on oral diets again. And usually it might often be a restricted oral diet. So I guess what I'm trying to say is I've never had the opportunity to see their group of patients like they had, and they had a large number of them too, who you had the opportunity to evaluate before and after a tracheostomy. I've never seen a patient before a tracheostomy, only after. And that would be typically if you're just an SLP in a hospital, any kind of hospital, but let's say acute care, that's who you're going to see. So I would say I'm suspicious of the results. I do question that. I don't know where they got those patients. I will say there's a logic to it, though, and I'll give you my few times of seeing a spinal cord patient who had had a tracheostomy because they had like a C1 or C2 or even C3 spinal cord injury to the point where they couldn't control their diaphragm and they couldn't breathe, and therefore they needed a tracheostomy. But their brainstem's just fine. They didn't have a brainstem injury. They had a spinal cord injury. And when you go to do the swallowing evaluation on those, many times they really can swallow just fine in spite of their tracheostomy. So I understand what they're saying, and I think it's got some credibility. I'm just not quite sure that it's got 100%, that it totally 100% accounts for it. But anyway, take a look at that study. It's a really important one, and you will hear about it often if you get into this, working with this group of patients. Okay. Well, now the slides that come after this, several of them, assume that the tracheostomy does affect the swallowing adversely. Because what I'm going to go through is a series of things that you can change about the tracheostomy tube. You can't change the fact that somebody has a tracheostomy, but you could change the characteristics of the tube in ways that will promote a better swallow. And this is, I don't think there's any SLP who would disagree with that. That when we go do a swallowing evaluation, somebody who has a tracheostomy tube, regardless of whether it was the original etiology, i.e. the stroke, for example, that caused dysphagia, or it was the tracheostomy itself that caused the dysphagia, we start changing things if they don't pass their swallowing test. So I just want you to know the variables that the SLP has at their disposal to change and how these things might affect the swallow, the integrity and safety of the swallow. First variable, which we've already mentioned, is the brand, Shiley and Portex. So you're going to have to deal with that. And I don't think there's ever an occasion to recommend a change in the brand, except if they have a Portex and they progress to the point where you think they might be able to independently use their Passimir valve, and patients do. Some patients use it all day long, and they can even take it on, put it on by themselves, take it off and put it on by themselves. So if you get a patient who's got to that point with their Passimir and they have a Portex, you want to get it changed to a Shiley, because remember, the Portex is not safe for independent use of the Passimir valve. This second variable is the size of the tracheostomy tube. They come in different sizes, for infants all the way up to large people. And I'll just take the numbering system of the Shiley. It goes 2, 4, 6, 8, 10. I don't think there's bigger than a 10, but the 10 is the biggest one. And basically it is longer, but it also has a larger diameter. And for an adult, typically when they first do a tracheostomy in an acute care, they'll use a Shiley number 8 or 10, depending upon the size of the person. And they want to make it sure that they get enough air through the tube, the inner cannula of the tube. They don't want to mess around, basically. And as they progress and do better and better and better, they can start to reduce the size. The second is the cuff status. And there are these different variables here. They can come cuffless, and you've seen a cuffless Shiley, and I think a cuffless Portex too, and they come with cuffs. If they have a cuff, the cuff can be inflated or deflated. They'll always start, if they put a Shiley tracheostomy tube that's cuffed into a person at the start, they're going to probably inflate it. They want it to use for mechanical ventilation, and they want to prevent any aspiration that they possibly can. And as they get better and start getting off the ventilator and start breathing on their own, and they don't seem to be aspirating their secretions, they will change them to sorry about that, to deflated. In other words, they can leave the tube in and just deflate it. And the final variable would be the fenestration status. Now, I haven't mentioned this fenestration yet, but I'm going to show you a picture in just a minute. In order to promote speech, using a speaking valve, mostly using a speaking valve, this thing called a little extra hole in the tube can be added to the tube. It has to be a new tube, but it has a fenestration in it that allows for additional air to pass up through the tube so that the person can speak if they couldn't speak with a regular tube, a non-fenestrated tube. And this will, where is my fenestrated tube? I don't know why I put it here, but I'm gonna go show it to you. It's, I think, the last slide. This is a Shiley fenestrated tube, and you can see all the different parts that we looked at: the hub, the phalange, the outer cannula, the cuff, the pilot. And then it's not very easily seen, but if you look real closely, you'll see there's a little kind of a hole here, and there's a matching hole on the other side. Those are the fenestrations. And if you put an inner cannula in that does not have matching fenestrations, which you certainly can do, they don't have the benefits of the fenestrations. If you put a fenestrated inner cannula in, there's actually a hole here that goes all the way into the inner cannula. And then as the person breathes, and you generally would do this with a cuffless or a cuffed deflated tube, as the person breathes, it can come not only up and around the tube, up and around the tube and up through the upper airway to vibrate the vocal folds and to be articulated with, and also up through the tube to this point and through the fenestrations, and then up the rest of the way through the upper airway. So I want you to understand how, when you're going to speak and breathe around the tube, where the air goes around the tube, between the tube and the tracheal wall, and then where it goes with the fenestrations. And look at the videos that I provided, and you will clearly see this. Okay, now I should reposition that to where I wanted to, but I guess I thought of it as an extra. So let's go back here. So we've gone through these variables, and what will tend to happen is when you do your initial eval, and you find that the person you deflate the cuff if they have a cuff, or they have a cuffless, one or the other, deflate, or they already have a cuffless, and then you see if they can talk around it or pass air around it, even go, and if they can't, and you try to use the passing ear speaking valve and they can't do it because they're not passing enough air through the larynx, you start to change the number 8 to a 6, which is about the smallest you can do on an adult. You can go 10 to 8, or then to 6, but not to 4. That would be for a child. And you make sure you either have a cuffless or a cuff deflated tube. And if all that still does not work, put in a fenestrated, which is a new tube, by the way. So you have to get a physician's order, and they have to take out the old tube and put in the new tube. Generally, either the physician or the respiratory care practitioner will do that. That would not be in our scope of practice. Okay. So this is just an overview of the clinically relevant variables having to do with the tracheostomy, or the tracheostomy and the ventilator that the SLP will deal with as you try to take a person with a trach who cannot successfully swallow safely and start changing things so that they can. One would be the ventilator status, and you know that assist control is going to be the most difficult, the most challenging. Not to say that anyone who has AC cannot swallow, but most of those are not going to be, or many of those are not going to be successful. Their breathing is too messed up, and they're receiving too much assistance from the ventilator. The second would be the presence or absence of a one-way valve. The valve will help the swallow, and it's been actually demonstrated quite clearly. Take a look at the passing ear materials, that if you have a valve on, it's more likely that the swallowing will be safe and successful. You can clear your throat with the valve in the same way that a normal person does. You push air up through the upper airway and potentially then into the pharynx and swallow it again, or cough it out your mouth if you want to. They can cough, they can clear their throat. They have a normalization of the subglottic pressure during the swallow. Remember, during the swallow, you're going to inhale, swallow, including closing the glottis, and then exhale. And if you have that passing ear valve on, you will have a normalized subglottic pressure. Then of course you have to think about all the other variables that would be relevant for a non-tracheostomized patients too. So everything you already know about swallowing evaluations and clinical swallowing evaluations, it all applies. The types of swallowing assessment that we would do would be, of course, you can do FEES, and you can do modified barium swallow, and you can do a clinical swallowing evaluation too, but it's referred to by a different name as opposed to just a clinical or bedside swallowing evaluation in persons who have tracheostomies or trachs and vents. It's called a modified Evans blue dye test. Typically, we just call it a blue dye test, but the proper name is really a modified Evans blue dye test. And I want to first explain what is the modified, what is an Evans blue dye test, because we're modifying it for a purpose of our swallowing assessment. Respiratory care practitioners and pulmonary physicians have been using the Evans blue dye test for a long time in order to determine if somebody can swallow their secretions. We're not even really talking about eating, but just swallow the secretions safely enough to not need their tracheostomy tube cuff inflated. In other words, to take a step toward decannulation and normalization. So they're talking about patients who have a trach tube and the cuff is inflated, whether or not they're on a vent. And what they'll do before deflating that cuff is they'll take a little blue colored water. They make the water blue with just food coloring and a little straw, and they'll dip that straw down into the blue colored water and put their finger on the end of it. And so they'll have about, so much straw filled with blue colored water. And then while the patient's lying down, they'll just gently pipette it, put the straw in the side of the mouth, down in the buccal area, and let it run out. And they'll do that just a small amount like that. And then they will wait a few minutes, and then they'll do the tracheal suctioning. And there shouldn't be blue. If there's blue there, they know that the patient is not adequately protecting their airway, and they still need that cuff inflated. And then they'll continue to suction occasionally for 24 hours and record all of those results in the in the medical chart. So the passing the Evans blue dye test means that they don't ever have any blue in the secretions for 24 hours. And then the physician knows that they can do away with the cuff inflation. Generally, they'll just start deflating the cuff. And the next time they change the cuff of the tracheostomy tube, which is about every month, if they still need it, they'll put in a cuffless tracheostomy tube. And so they're on the way to decannulization and getting rid of the whole thing. That's an Evans blue dye test. It's done by respiratory care practitioners and of interest to the pulmonary physician who's trying to figure out, how to manage the patient. Well, SLPs, saw that and said, well, let's just color everything blue, and then we can sort of do a clinical bedside swallowing evaluation with everything blue. And then instead of listening with a stethoscope and listening to voice, which you can still listen to voice, by the way, but you can, in addition, periodically suction through the tracheostomy tube, and if they show blue, they aspirate it. Or you can also just ask the person if they can to cough through the tracheostomy tube. If they cough, it's going to come through the tracheostomy tube. And if it's blue, they aspirate it. So that is the modified Evans blue dye test, or as SLPs refer to it, the blue dye test. It has all the elements of the clinical swallowing eval. And before we start giving them blue things to swallow, what we want to do is assess them a little deeper to see if we could get the patients into the optimal situation for swallowing. So very often you get an order for a swallowing evaluation on a patient who has a cuff inflated tracheostomy tube, and they're either on a vent or not, but the cuff is inflated and they don't have a speaking valve. And because we know that the speaking valve positively affects swallowing, in a positive way, I should say, and cuff deflation positively affects swallowing in a positive way, we would like to try it with tracheostomy cuff deflated and a passy mirror valve on. But before you can do the swallowing, you have to figure out if they can tolerate deflation and if they can tolerate a passy mirror valve. By the way, that requires a physician's order. If somebody has a cuff inflated, you don't just go in and deflate it. You call up and say, I know you wrote an order for a swallowing evaluation, and I'd like to be able to try it with the cuff deflated and a passing mirror speaking valve if the patient can tolerate it. Is that okay? And the doctor says, okay. You write an order in the doctor's name, of course. And sometimes they'll say, well, why? And you have to show them that the research shows that for the population of patients with a possible dysphagia and a tracheostomy tube, they do better with the cuff inflated for swallowing and with a passing mirror speaking valve on. Now, that doesn't mean it's best for every patient. It means it's best for the average patient or for the population. So that it may not work for your patient, but that's what you're going to try, and you're going to try it in a very conservative way that won't jeopardize the patient, as you'll see. And then once we get them to that optimal condition, so let's say they did tolerate the valve and you've got it on and they have cuff deflated, and then you do your blue dye test. So what you're going to do is put that blue dye into materials, and you're going to go through the standard, more or less the standard procedure. And the difference would be that instead of relying just on phonatory sounds and upper airway sounds with auscultation, we are going to do suctioning. And we're going to do it a maximum of 3 or 4 times through the entire evaluation. The reason for that is because tracheal suctioning is traumatic. Sometimes you'll see patients being tracheally suctioned, and there is blood in the secretions. Why? Well, quite possibly because that tube is scraping against the tracheal wall and causing abrasions that produce blood. So even if the patient cannot tolerate cuff deflation, we need to deflate the cuff for the purpose of suctioning. So let's say the physician said, no, you can't deflate the cuff because the patient needs that. Do you say, well, I'm going to do a blue dye test, and in order to have anywhere kind of a close, anything close to valid, we need to deflate for the purpose of suctioning, and then we'll inflate immediately. So you're only going to deflate for 30 seconds, maybe less. Deflate, allow materials that might have been aspirated below the trachea, excuse me, below the glottis, but then they're resting on top of that cuff, inflated cuff. And then you do your suctioning, which is the tube is going below the tracheostomy tube, and the materials that have been aspirated are not there yet. So you get a good result, but it's false good result. So that's why you need to deflate and allow the material to run down so it can be suctioned up and show it's blue, if it is blue, if they haven't aspirated. So remember that rule. Cuff must be deflated during suctioning, but can be inflated during actual swallow, if that is the condition that the patient would potentially be eating and swallowing in. Which if the physician says, no, you can't deflate the cuff because they need that, they might need it for the positive ventilation, positive pressure ventilation, or they might need it because the physician is so concerned about aspiration. They want you to test it, but they don't want to just have it. They're very concerned with it. So, and then once you get a positive blue result for any swallow, and remember you can only do 3 or 4 times because it's traumatic, the test ends. That's it for that day. And then we try to learn what we can from that test and go back the next day and repeat it. We can't repeat it right away because the materials will continue to be blue that we're suctioning from the trachea from that one bad swallow. I hope that makes sense. You get one bad swallow, and then maybe you say, oh, well, that was nectar, I'm going to give honey. And you give them honey, and maybe it was a good swallow, maybe it's not. You don't know because you get blue again. It's from the first swallow. All right, so possible recommendations that we might make in our evaluation after our first modified Evans blue dye test, because remember, we're going to write an evaluation. We're not probably going to put them on a diet yet, but we're going to write an evaluation. And the possible recommendations are that the patient continue to be NPO if they are, that we reassess, probably going to be reassessed tomorrow. Sometimes we'll just go ahead and ask for serial modified Evans blue dye test order to allow us to do a number of them in a row each day, one today, one tomorrow, one the next day, without having to call the physician each time to get a new order. We may go ahead and ask for an instrumental assessment, which could be the MBS and occasionally, and this will be very occasionally, we may start in a PO diet. And honestly, the only patient I've ever started a PO diet based upon one blue dye test was a spinal cord patient who did so perfectly. He ate practically an entire meal, and well, he didn't hold the cup. I held the cup, but he drank from a straw an entire cup of blue-colored water, and there was no blue. So we'll talk about the reliability of the test, which is not real good. It's not great, but if the patient passes an extremely intensive test and really wants to start, I might start based upon one diet, one test. But I'd still go back the next day and retest just to make sure. All right. Here is a chart you've seen many, many times, suggesting an order. And again, you can see I'm starting with a teaspoon of nectar, and I'm progressing, if they get there, to sequential functional doses of solid. And all the 2s and the 3s are kind of variable depending upon what you're finding. Okay. Little more on the why we want to use a one-way valve if we possibly can. And I had said this, but I want you to see it. Normalizes subglottic pressure during the pharyngeal phase, allows for throat clearing and coughing to clear the upper airway. And we are only going to be using a one-way valve if we can deflate the cuff. And that deflated cuff allows for greater laryngeal elevation during the swallow. We talked about the appearance of the valve. You know what they look like. We have not talked about the placement very much. I'm going to reiterate this in additional slides here. But we will put that valve on only after we have deflated the cuff on a tracheostomy tube. I bolded it, I underlined it, and I put it in red. So we are only going to put tracheostomy, only going to put a passenger valve on a tracheostomy tube after, not before, the cuff is deflated. And remember, some of them don't have a cuff. Occasionally, you'll find a patient like that, and then that's not an issue. When we're going to go that route with the passenger valve, we first need to assess the tolerance for the valve. And if they do not tolerate it, we remove it immediately. Now, how do we know if they don't tolerate it? I've got it on another slide, but basically you're looking for any evidence that they can't breathe around the tracheostomy tube. And you'll hear it in stridency. You put that valve on, you hear, originally, and this would be breathing out. Breathing in, fine. Why am I hearing that? Because they can't get the air around the tube. The tube is too big and up too tightly against the walls of the trachea. So that's one. We will also test for oxygenation, and if their oxygenation starts to go down, I've got some details on that, but if the oxygenation starts going down, we'll say, well, they can't tolerate it, and we will troubleshoot that, but we're not going to be doing our swallowing evaluation on that day with that setup because they can't tolerate it. If their heart rate jumps up, that's a problem, and if their respiration is struggling, if you can see if their respiration is struggling. So if they can tolerate it, and you may judge, tolerate it for a minute or 2 minutes, something like that, we could go ahead then and see if they can voice and if they can speak with that valve. And after you found out all that information, it doesn't take a long time, you can go on with your swallowing evaluation. But why are we talking about it now? Because we'd like to optimize the conditions for swallowing by having that valve on if we can. In addition, of course, we're interested in having the person communicate. So as SLPs, we will address that too. At the moment, it's not my big priority, but it's very fast to figure it out if they can tolerate it. And occasionally you put that valve on and people start talking. It's very, very impressive when they do that, and they're amazed by it. Okay. So overview of the suitability for the use of the one-way valve. First is medical suitability, respiratory status. Patients who are on assist control, possibly not. Patients who are requiring a lot of suctioning because they've got secretions, possibly not. And you'll get to be, pretty close with your respiratory care practitioners to the point where you trust them and they trust you. And you get an order for a swallowing evaluation and you ask for their assistance, particularly if the patient's on a vent. And they'll say, oh, I don't think they can do it. And they can tell you why too. Or the physician sometimes can tell you, but typically they wouldn't have asked for a swallowing evaluation if they didn't think they might be able to. Let's see, the types of valves, we've already gone over this. There's one-way trach valves and one-way vent valves. First, we're going to assess their tolerance, then we're going to assess their speech, and then we're going to assess their swallowing, if they can tolerate it. Details of assessment of tolerance of one-way valve. If they're on a vent, we need to plan in advance for the connection. You do need that little adapter that goes from 18 to 25 millimeters. If you go in there just with a patient set up on a vent and you've got your little valve, you're passing your vent valve in hand, you got almost everything you need, but you don't have the connector and you will not be able to set it up so it's in line. But assuming you've got your connector, you can actually attach the two pieces together. So one end will go on the T-bar and the other end will go in the blue tube. And it's simple. So you take in two parts, a valve and an adapter. And I always take a respiratory care practitioner because in case they need to make any settings, changes in the settings of the vent, they'll be there. Then you want to make sure the cuff is deflated. You want to make sure the patient and anybody else in the room with you that knows what's going on, that they should know what you're going to do. And then before you do anything, You're going to make sure you know what their baseline O2 saturation is. You do it with a little device that can just simply fit on the finger called a pulse oximeter. You can buy one at CVS for like $25. If the patient is on a monitor in ICU, they already have that. They already have a little device to measure it, and you can look up on the screen and you can continuously see what their O2 saturations are. What's normal? 90% or better. So if you go in and they're at 88%, you're probably not going to be doing this anyway. But if it's 90%, you're going to be saying, okay, that's good, or better, could go up to 100. Then you start tracking it as you go through your process of putting that valve on to make sure it does not drop below. If it drops below 90, it means that they're not tolerating the valve. You're also going to look at their heart rate. Now, what's a normal heart rate? Someplace in the 70 to 110 would be reasonable. Whatever it is, if it's in that range, you're going to know what their baseline is at that particular moment, and then you're going to make sure it does not go up more than 10%. If they're in ICU, again, that's monitored, so you can look at the number at any time and it's there. Make sure you don't go over 10%. You want to make sure the respiratory rate doesn't go over 10%. So sometimes you have to measure the heart rate, and you have to measure the respiratory rate yourself manually. Let's say if you're using a finger pulse oximeter that is the little portable $25 one, it will also show the pulse rate. So very convenient. Or the heart rate. It won't show respiratory rate. You have to measure that by observing. You can listen for respiratory stridency. So before you start doing anything, you just want to listen to that patient breathe. And what are you hearing around here that sounds like? Again, I'm doing that on inhalation. That's wrong. The patient is inhaling through the trach tube. They'll go. They're having trouble breathing out. You're listening for that stridency. And you want to look at the appearance of comfort that they're having. And hopefully you don't see a change. So if you see any of those indicators change, you're going to take that valve off. But let's say everything looks okay. O2 saturation is 90 or better. Heart rate is 70 to 110. Respiratory rate is 12 to 20. You don't hear any stridency and they look comfortable. Put the valve on. And then you continue to monitor. You don't really do anything. You just continue to monitor for a minute or two at least. You should certainly do more if you're not sure, but you monitor for a minute or two. You don't just put it on and go 15 seconds. And if you see any problems with any of those indicators, you take that valve off right away. And then you're going to start troubleshooting. Troubleshooting means usually I would go in the next day and try it again, not change anything. But then the things that you're going to be doing, if they still can't tolerate it, we're trying to maximize their swallowing by using the valve if we can. Downsize the trach tube, go to cuff deflated. Excuse me, you have to deflate to put the valve on, but you go to cuffless if the physician will allow that, and you can go to fenestrated. Okay. And how do you check speech production? First of all, make sure they're tolerating. Then you just ask them to voice in a variety of ways. You can obviously go through kind of like a little motor speech evaluation where you start with phonation and then you go to pa-pa-pas and ta-ta-tas. You can simply ask them something that's very spontaneous, like, hey, like, how does that feel? Or what's your name? You know, how old are you? Stuff like that, where you kind of have almost a reflexive or automatic type of response, which can sometimes be better in some patients, especially if they have a cognitive disorder. The more naturalistic the whole testing situation is, the better they'll tend to do. And the more structured and laboratory-like you make it, the less they're able to participate and produce meaningful responses. All right, these are the fenestrations, and I had jumped ahead to show you this as an option. And I think that is it. So I'm going to stop sharing, and I will see you later.